Okay, welcome everyone. We're going to get started here. I just wanted to give everyone a moment to come in from the waiting room into the call. But welcome to our second day of the Ocular Melanoma Patient and Caregiver Symposium. My name is Jasmine McGowan. For those that don't know me, I'm the Managing Director here at Save Your Skin Foundation. And we will get started in just a moment. I just want to go over a few things with you all today and talk about some Zoom housekeeping rules. So today we do have a discussion that is going to be taking place between Kathy and Nigel. And for this, we do ask that you use the Q&A feature at the bottom of your screen while the presentation is in progress. If you can't use the Q&A feature for whatever reason, please feel free to use the chat, and we will go over the questions and discussion points, comments, or concerns that you have at the discussion period today. I do want to let you all know that this call is being recorded, of course, but the one yesterday, if you missed it, was recorded as well and will be available on our YouTube and on our website in the upcoming days. And yesterday included presentations from Dr. Butler, our patient story from Sherry, and our memorial video for Dr. Sue Johnson by her husband, John Douglas. But today we have an incredible agenda, so I am going to pass it on to our host for today's call, Nigel Deacon, and we will get started. Nigel?
Thank you, Jasmine. And a big thank you to everyone joining us on day 2 of our symposium. For those who missed yesterday, my name is Nigel Deacon, and I'm your host for today. So we've got lots of things to do. Today, we'll start with a presentation from Castle Biosciences, followed by a discussion between myself and the founder and president of Save Your Skin Foundation and Ocumel Canada, Kathy Barnard. And then we'll close the day with a guided wellness session led by Lyanne Westie, Save Your Skin Foundation Wellness Support Consultant. So let's get started with our first presenter, Dr. Katherina Alsina from Castle Biosciences.
Hi, everyone. I'm Kat Alsina. I'm with Castle Biosciences, and I'm going to give an overview of the genomic testing services that Castle provides for uveal melanoma tumors. So just to start out here, for those of you who aren't familiar with Castle, we are a US-based molecular diagnostics company. We have a wide range of different diagnostic and prognostic tests that spans a wide range of diseases, and you can see that on this slide. And our uveal melanoma test, DecisionDx-UM, which is listed there at the top, was the company's first successful commercial test. It became clinically available way back in 2009. So we have a long history supporting patients and the incredible community of physicians that treat this disease. And we're very honored to be here supporting this meeting and appreciate the invitation to talk to you today. So I'm going to tell you a little bit about the testing that we do for uveal melanoma, but just to step back and orient everyone, DecisionDx-UM is the main prognostic test. It's very commonly known as the GEP test, that stands for Gene Expression Profile. And this test looks at the tumor's biology and tells us how risky that tumor is, or how likely it is to spread outside of the eye to other organs in the body. And then the two tests listed below it, DecisionDx-PRAME and DecisionDx-UM-Seq, are additional tests that we can run from the same biopsy specimen that can really help supplement the information we get from the GEP test. There are several reasons that this type of testing is important, because knowing the riskiness of the tumor helps to determine how often to monitor patients and scan for metastatic disease. It can help the patient's treating doctor decide whether that patient needs to see a medical oncologist and how often to schedule follow-up visits with them. And it can help guide discussions around clinical trials and help determine if that patient might benefit from enrolling in an adjuvant therapy trial. And so this slide kind of shows where testing fits into the bigger picture, the patient journey through this disease. And I don't want to go through the whole slide, but I'll just highlight a few points here because there's a lot that can happen between the time the tumor is first identified to the time that it's treated. Sometimes multiple doctors are involved before the patient can get a formal diagnosis, but the hope is that as soon as a suspicious lesion is identified, the patient would be referred to a specialist with experience treating eye tumors. So I don't know if you can see, hopefully you can see my cursor here. And then those specialists will do a comprehensive clinical evaluation of the tumor where they measure the size of the tumor. So they'll look at its thickness and its diameter and exactly where it's located in the eye. And then they can use that information to come up with what's called the tumor stage through the AJCC staging system. And so that system takes into account all of these different clinical features of the tumor. But we know that the staging system is limited in terms of its ability to give a patient really personalized risk information. And unfortunately, many patients who are identified as low stage will end up developing metastatic disease. And that is where tumor biology can really be helpful to give patients much more accurate molecular information about their cancer and their individual risk of that cancer spreading. So it's now very common for patients to have a biopsy sample taken right before the eye tumor is treated. And the most common treatments are shown on the left here. They're radiation therapy with plaque or sometimes proton beam therapy. In about 10% of cases, at least in the US, the eye may need to be enucleated or removed. But either way, no matter what that treatment modality is, a little sample of the tumor tissue can almost always be obtained from the tumor for testing. And so that's where Castle's testing comes in. And so now let's do a deeper dive into what these tests are. I know some of the text on these slides is kind of small. I apologize for that, but I'll describe everything as we go. So we start with a little bit of tissue from the primary tumor. That's the tumor in the eye. And that tissue can be fresh tissue if it's taken with a fine needle aspiration, or it can be fixed tissue if the eye was enucleated. Our testing has been validated on both of those types of tissue, fresh and fixed. And by validated, I mean that we've conducted extensive analytical studies, and those studies have been published showing the technical success of our tests in both tissue types. And that validation step is really important. And it's something that I always emphasize because we pride ourselves at Castle in making sure that our tests are backed by rigorous scientific evidence. And to me personally, as a scientist, I really value that. So you're going to hear a lot about scientific data throughout this presentation, but I'll do my best to keep it high level. Anyway, all these tests can be done from the same starting sample, which is pretty amazing because these eye tumors are tiny and the samples taken from them are tiny. We're talking like a few hundred microliters of tumor. And we've shown that we can obtain actionable results for patients about 97% of the time consistently. So that's a very high technical success rate. And I mentioned on the previous slide that DecisionDx-UM is our main test. I'll probably call it the GEP test at times, but because that's a little easier to say. But then the other tests we do are the PRAME test, DecisionDx-PRAME, and our sequencing panel, DecisionDx-UM-Seq, that looks at DNA mutations. And so taken all together, these tests offer a really comprehensive molecular picture of the tumor, and we can get all of that genomic information from the same starting sample. These are the results that each of the three tests gives, and I'm going to break it down and go through each of them, starting with the GEP test, DecisionDx-UM in the middle. This is a test that looks at expression levels of a number of different genes, 15 genes in the tumor, and then puts all of that gene expression information together into an algorithm that gives a classification. Class 1 tumors have a lower risk of metastasizing within 5 years, and Class 2 tumors have a higher risk of metastasizing within 5 years. And we can further subdivide those Class 1 tumors into Class 1A and Class 1B groups, which gives us a little bit more refinement about the patient's risk. But now there are other ways that we can refine that risk information, for example, incorporating PRAME status. And I'm going to talk about that a little more at the end, because we have some new data about PRAME's role in combination with the GEP class. But first, just to keep things simple, and because the GEP information is really the most important, we're going to focus on that test. The GEP class has been shown to be the strongest kind of risk factor compared to all other risk factors, but these other tests provide additional pieces of information that can be informative when they're taken in context with the GEP class. So the GEP test has been extensively studied. It has undergone a high level of validation through multi-center prospective studies. And because of that, it has been included in the National Comprehensive Cancer Network guidelines for uveal melanoma ever since they were first developed for this disease back in 2018. And so here you can see what the guidelines recommend. And that is that the test can be used to help guide metastatic surveillance plans and discussions about adjuvant trials for those patients who are most likely to benefit from adjuvant therapy, those high-risk Class 2 patients. And I want to talk a little bit about the first clinical validation study supporting the test. It was conducted by the Collaborative Ocular Oncology Group, or COOG group, and this study included 459 patients from 12 centers, and all of these patients were prospectively tested. That's important because they were followed, kind of in a forward moving way. And as you can see from the donut chart, that red and blue chart on the left, about 60% of the tumors in that study were Class 1, so they were low risk, and about 40% were Class 2 or high risk. And on the right, you can see the outcomes for those patients based on their GEP class. And so that separation of those two lines is really striking because it clearly demonstrates that the test was able to differentiate risk between those two groups. So after 5 years of follow-up in that study, 97% of the Class 1 patients still remained metastasis-free compared to 20% of the Class 2 patients. And when the investigators compared the result of this test, the class result, to all of the other risk factors that are known to be associated with metastasis, they found that the class result was the most robust predictor of metastasis when compared with clinical features and pathology features and chromosome status. Now, since that initial COOG validation study, we call it the COOG-1 study now. Since then, many additional studies have been published, and those are all listed on this slide. And those studies support use of DecisionDx-UM, that GEP test. We now have over 25 published studies that have included more than 5,000 uveal melanoma patients, which is really an incredible body of evidence for such a rare disease. And I want to take a moment to highlight the study at the very bottom, which evaluated patient perspectives towards prognostic testing. So this was a study that was actually done in collaboration with an advocacy group, the Melanoma Research Foundation, and their CureOM initiative. And it found that patients really desire and gain value from prognostic testing, from molecular prognostic testing, regardless of whether they receive a high or low risk result. So that's, I think, very powerful data highlighting the patient voice. And so I showed that there's a lot of data supporting the DecisionDx-UM test, the GEP test. But what about these other tests? So I want to talk a little bit about those, because in recent years, we have evolved our GEP testing platform to be able to identify these other biomarkers like PRAME and like the DNA mutations. And again, all of this information can be obtained from the same initial biopsy sample. So starting with PRAME at the top, In 2016, this gene called PRAME was identified as a new biomarker with potential prognostic value in both class 1 and class 2 uveal melanomas. And so Castle began offering a single gene test, so it just looks at PRAME, and it uses a validated threshold to distinguish PRAME negative from PRAME positive tumors. And PRAME positive tumors had been shown to have an increased risk of metastasis. And I'll talk a little bit more about that on the next couple slides. And then jumping down to the bottom of the slide with the DecisionDx UM-Seq panel, that panel was developed a little later in 2018 to be able to profile the most common uveal melanoma associated mutations using this specialized panel. So we're now able to collect a lot of molecular information with these additional biomarkers. And the next question really was, what do they add to the GEP result? What do they add to the class result? Is there an optimal way to kind of think about these biomarkers together for even greater prognostic accuracy? And that question is the subject of an ongoing study. It's also conducted by the Collaborative Ocular Oncology Group. And so it's their second multi-center prospective study. It's called the COOG-2 study. And this has really been an incredible collaborative effort across 26 ocular oncology centers in the US and Canada. And here you can see the investigators who led the study. So some of these faces might look familiar. And so what's cool about this study, it is the largest and most comprehensive study to date that has evaluated Castle's 3 molecular tests in a large group of patients. The first report from this study was just published in the Journal of Clinical Oncology, which is a very well-respected journal in the field of cancer research. So we're very excited to see that published. And it included more than 1,500 patients that had testing with the GEP and with the PRAME test. And the main finding from that study gives us the first strong data around PRAME's contribution to metastatic risk. What the study found, and I'll show some of the data in a second, is that PRAME really works to fine-tune risk for both class 1 and class 2 tumors. And so that's the snapshot of the publication. So I want to show you what the data looks like from the study. On the left is a graph of metastasis-free survival, where you can see separation of 4 distinct groups. The top 2 lines are class 1 tumors, which separated out depending on whether they were PRAME negative. So that's PRAME negative, class 1 PRAME negative at the very top, the dark blue line, or whether they were PRAME positive, that's the teal line right underneath it. And then similarly, the bottom 2 lines are the class 2 tumors, and you can see those also separated out depending on whether they were PRAME negative, which is orange, or PRAME positive, which is red. So those class 1 and class 2 tumors were sub-stratified. They were subgrouped depending on whether they were PRAME negative or PRAME positive. Additionally, just like with the first validation study, there were a number of other risk factors that were evaluated in these patients, and the DecisionDx class result was found to be the most robust predictor of metastasis when compared to all the other features, including PRAME. PRAME on its own wasn't a great predictor of metastatic risk, but when you combine it with the GEP class results, you get this really excellent stratification. And so you can see the specific metastasis-free survival estimates just listed out in the table on the right. So for the class 1 PRAME negative group, the 5-year metastasis-free survival rate was 96%. For class 1 PRAME positive patients, it was 81%. For class 2 PRAME negative patients, it was 58%. And for class 2 PRAME positive patients, it was 45%. So that is the newest data around PRAME. What about the DNA mutations from the sequencing test? So I'm going to tell you a little bit about the sequencing test and where we are right now with the sequencing data. This diagram shows the 7 genes that we can look at using our targeted sequencing panel, DecisionDx-UM-Seq. A majority of uveal melanoma tumors will harbor mutations in genes that activate a G protein signaling cascade, and those genes are the ones that are shown in red: GNAQ, GNA11, PLCB4, and CYSLTR2. And mutations in these genes have not been found to have any prognostic value, so they're not helpful for determining metastatic risk, but their presence can be used to help confirm that tumor cells were actually sampled. So in the case of a fine needle aspirate biopsy, when you just have a little needle biopsy of the tumor, that can be helpful for sampling confirmation purposes. And they're also promising candidates for targeted therapies. In terms of the other 3 genes that we look at, EIF1AX on the right in green, SF3B1, and BAP1. Mutations in those 3 genes occur relatively later in tumor progression, and they are thought to be associated with different metastatic risk. So one big question was, well, if these mutations tell us about risk, what do they add to the GEP and PRAME information? And the short answer is that these mutations don't really add any additional prognostic value above and beyond GEP class and PRAME status. So if GEP class and PRAME status are known, these additional mutations won't be very helpful. But if for some reason GEP and PRAME status are not obtained, then having mutation information could be valuable for providing risk information and could potentially help qualify a patient for a clinical trial where mutation status is required. So there is definitely a role for sequencing as an ancillary test, as a supplemental test, but it doesn't seem to be helpful for risk prediction, at least when GEP and PRAME status are already known. And those data are also currently being prepared for publication by the COOG group. So we look forward to seeing those published sometime soon. And that is all I have. Please feel free to reach out if you have any questions about Castle's tests. We do offer international testing for patients who are outside of the US, so I'm happy to provide more information about how that works. Thank you.
Well, what a wonderful presentation by Dr. Alsina and the team at Castle Biosciences. She's a very good friend of Ocumel Canada and Save Your Skin and participated in our first symposium last year. We're now moving into our second session, what patients and caregivers need from Ocumel Canada moving forward. What needs are not being addressed. You can interpret it more broadly as you wish. And I'm pleased to welcome Kathy Barnard to join me for this discussion. Kathy is the president and founder of Save Your Skin Foundation, Ocumel Canada, and a passionate advocate for patient care and support. She played a key role in implementing federal tanning bed legislation for Canadian youth and continues to focus on education, awareness, and providing emotional, financial support for those affected by melanoma and carcinoma skin cancers. Diagnosed with malignant melanoma in 2003, Kathy's prognosis was terminal by 2005. With determination and limited support, her family found a trial immunotherapy treatment that extended her life. This journey led to the founding of Save Your Skin Foundation in 2006, ensuring no one diagnosed with melanoma would face their battle alone. Kathy's ongoing fight against melanoma in all its forms drives her advocacy for equal, timely access to new treatments and support for cancer patients. Her dedication and achievements, including receiving the British Columbia Community Achievement Award, highlight her leadership and impact. As we begin the discussion, please use the Q&A feature at the bottom of your screen if you have questions. If we can't address your question today, we'll follow up via email later. So let's get started. Kathy, would you like to say a few words as we start?
Hi, everybody. Welcome to day 2. Thanks for joining us. Nigel, if it's okay with you, why don't I take the first few minutes to kind of talk about why Ocumel Canada is so important to me at Save Your Skin Foundation, and then kind of set the stage for how the process works, not just in Canada, but across the globe. And then patients will probably maybe have a little bit of a better understanding of why treatments can differ between countries, but they also can differ within provinces right here in Canada. So firstly, Ocumel Canada really started because of our good friend, Nigel Deacon. As Nigel mentioned, when I was diagnosed with stage 4, there were no treatments for me. Believe it or not, they were still calling melanoma a rare cancer. So my family and I had to really do everything we could on our own to find treatments, to find clinical trials, and really learn and understand the healthcare system within Canada, which we all think is we go to a doctor, our needs are met, and we'll live happily ever after. And we found out very quickly as a family that's not really the case. So I was given a couple of palliative drugs to get me to one of the newer innovative medicines, which I actually had brought in from the States. They were going to charge me for it at that time. I couldn't even get it in British Columbia. I had to go into Alberta to get that drug. So it was a really hard process, but it was hard to understand why that process even existed in Canada. So I'll just kind of run through how processes work very quickly. Most of you know there's 4 phases to a clinical trial. We have stage 1, 2, 3, 4. Back in the day, which was not that long ago, Canada was only able to bring drugs into Canada if they were at the phase 3 and 4 clinical trial setting. We were never happy with that as patient advocacy groups. We were wondering, because we were already starting to see good data coming out of phase 2 data, the data that we were seeing. And we were kind of pushing for Health Canada and drug companies to start bringing those trials to us in those earlier phases, especially in cancers where prognosis wasn't good. Because for us, waiting for data and phase 4 trials to come in was ultimately for us that were given 3 to 6 months, too long. So behind the scenes, and I'll talk about Save Your Skin kind of sticks its nose into everybody's business, and Ocumel Canada now. So what we have said to anybody bringing drugs into clinical trial, whether it be in Canada or even before that process in the US or in Europe, we want to be at the table. We're saying, please do not build anything for us without us. So we actually are now invited right at the early onset of the design of those clinical trials. And we get to represent the patient, or we even actually sometimes will bring a patient to represent their needs throughout the clinical trial, processes. So we start there. Sometimes we're lucky enough to get one of those clinical trials directly into Canada, which I think most of you saw when we got the Kimtrack. Unfortunately, we were only able in the beginning to have access to that drug in one center in Canada. As you know, we have some big centers of excellence. We always have Princess Margaret. Early days, we had the Cross Cancer in Edmonton, Alberta. So for us at Save Your Skin, we knew as long as we had 2 centers of excellence, we would do whatever we could to financially and emotionally support patients all over Canada to get them to those centers. So as soon as a patient was moved or told to go over to Princess Margaret, we were there to pick up any of the financial needs those patients had. But behind the scenes, what Nigel and I were working on diligently is saying 2 centers is not enough. We want, and I know this personally, we want to be treated close to home with our support systems in our province, if possible, 2 hours max to a clinical trial site. And so we were working diligently to make sure that when that Kimtrack drug was coming out, that we were making sure we were getting sites up and running as quickly as we can. So we work very closely with the cancer centers across the country to get them up ready We get them mentored by Princess Margaret or Alberta to make sure we get those doctors moving. Then what happens is once those clinical trials, we start seeing those clinical trials in Canada, we then know the drug company is going to take that file to the federal government, Health Canada, for notice of compliance. So again, behind the scenes, we are working with Health Canada to ensure that once that drug gets to NOC, we can start going out and working some magic, because we want to make sure that drug is going to get to the patients as quickly as we can get it to them. So once notice of compliance happens with Health Canada, then the process starts to move not timely enough, but the process then moves to where it goes to a governing body called CADTH, which is the Common Drug Review. Used to be called that. It's just changed its name to Common Drug CDA. It's got a new name. So once the file gets there, that's when you start hearing from us, because that's when we have opportunity to come out to you, patients that have either had the drug or would like the drug, and say, and run our survey questions through you. Once we compile that information, we make sure that we translate everything to French, because it's not just one drug agency in Canada. We have TRUE. CDA or CADTH is all of Canada except Quebec. Quebec still does its drug approvals alone through a group called INES, but we make sure when we do our surveys, we do them one time fits all for patients. We get them ready. When we hear from CADTH that it's time to submit, we will then send our survey report that you have done over to CADTH, and hopefully and we know it's part of the drug review process. We also send it along to INES. Sometimes INES will come out and ask for the survey data and patient information first. Sometimes it's CADTH. We never know which one of them is coming out to take a look at the surveys first or second, but we're always ready, waiting for those dates to come out. So once we've gone to CADTH and INES, then we sit waiting to see what their initial review will be. Generally, we hear it takes about 3 to 4 months for us to hear their initial review. We then get to come back and give comment on how we feel that first recommendation went, whether we agree with it in principle or not, if we would like to see some changes to that review. We work simultaneously with all of the melanoma task force, both ocular and cutaneous task force of physicians, to make sure we're including their input as well. Once we get a positive review through the CADTH and the INES, it then goes to a governing body called PCPA. And that's where they start negotiating the price. As most of you know, the price of these innovative medicines is extremely high. So we usually have a province take the lead at the PCA table, and they start doing the drug negotiations. That's the only one time that Save Your Skin and Ocumel Canada have no concept of what's going on behind the scenes. We are not part of drug review process. We don't want to be. We really shouldn't be. So we sit monthly and we keep going on the PCA website to see if there's been any updates on the negotiations. Once it gets that positive recommendation, we're still not finished. That's when those files move out to every provincial jurisdiction within their cancer center and those budgets. So there's still a lot of process and a lot of work that needs to be done there, because then they're trying to find the budget for those treatments. So in all, this process from start to finish, once that file gets to NOC at the Health Canada process, can take anywhere up to 24 months for the first province to actually agree to get that treatment to the patient. It's a very, very long process. And I can't stress enough, Save Your Skin is at every table trying to move that faster, because we know that 18 to 24 months is not fast enough. And not only that, for some of our provinces, it's even well beyond that before they can find the dollars within their budgets to get that on formulary. So while we work closely with all the provincial agencies, even before it gets to them, to try to remind them and to show them the report that we've done from our patient data that's reminding them that they've got patients within their jurisdictions that need that treatment. We work with the private carriers as well, because sometimes we can get a private funder to pick that up before it's even reimbursed through the public system. So there's a lot happening within there. You know, in the ocular space, it's gotten a little bit more complicated because the drugs aren't coming from those big pharmaceutical companies that we saw in cutaneous. They're coming through the smaller bioscience companies in the US that don't even really have a big presence in Canada. So that's why it's really important that we're also working with those bioscience companies in the US to kind of build their recognition within Canada. So when their drugs are coming into the process, they are a known entity within the Canadian landscape. So that in itself has been a little bit of a harder process for us. So that's sort of how we're seeing all of the process through Canada. I know it's very complicated, very complicated. But again, we're really excited to say we make huge progress. We're really trying to see those clinical trials come to us in earlier phases. Nigel, you know how important that is to us. And if we see good data coming from a phase 2 trial, we try to hop, step, and jump a couple stages so we can get it right to NOC and right to the CATA, so we can get moving that process a little quicker. We were excited about 4 years ago when the government decided to bring in a project called Project Orbis, and it was for rare cancers, and they were promising that they would help speed up the process. Ocular melanoma is a rare disease, so we are hoping that moving forward, anything we're going to see start coming into Canada will take, I hope, significantly less than 18 to 24 months. And we will be holding the government accountable. They told us timely access through Project Orbis, and we absolutely want to see it in the ocular melanoma space.
Thanks, Kath. It's worth maybe adding that Kimmtrak is the only approved therapy for metastatic OM at the moment, because they've gone through the process of getting it approved by Health Canada. And it's also worth noting that it is available from Corner Brook to Victoria. So we did get what we wanted very, very quickly there. And as new therapies get approved, or as new therapies are tested in clinical trials, you know that Save Your Skin and Ocumel Canada will be there pushing the agenda forward. Could I also add, sadly, I'm not able to see who's participating. I was hoping that we would see whether Jamie Jessen, a genetic counselor who works for Impact Genetics, was with us, but I can't see the list. But I did hear just yesterday that Ontario is now picking up the tab for Impact Genetics testing for new ocular melanoma patients in Ontario. And that's huge because that's our largest population of patients. Quebec has been providing the testing in a couple of different ways for several years. So we know that Quebec patients have access to that testing. Dr. Weiss in Alberta, who works magic every day, has been, Alberta picks up the tab for the GE-PIT testing that Dr. Alsina talked about. So the work is smaller now, but the work still continues. There are a few outlying areas, BC being one of them, unfortunately, where it's not currently covered. But of course, if it is something that patients want, and if we know about it, we're very happy to help them get it. So that's another good news story that's just emerging. Oh, thank you. I see that Jamie is not with us. I just wanted to talk a little bit about the Facebook groups so that people are clear. We actually do have two. We've had a general group going for several years. So people are welcome to join, whether they have primary disease or metastatic disease. And the conversations and information sharing in there tend to be, general. Where did you get help? Who helped you? What do you do when? Kinds of questions. And then more recently, metastatic patients, who are in a dreadful situation, of course, wanted to be able to have conversations about their treatment and their quandary, and they felt it might be, upsetting or alarming to primary patients. And so a metastatic group was set up. It's a much smaller group. And at the end of the webinar, you will see both of those Facebook groups mentioned so that you can join either or both depending on your particular situation. We do have the chat function open, and so if you have questions that you'd like to ask us, we'd be very happy to do that. We got one medical question yesterday, which we will forward to our medical experts. So if medical questions come in, that's what we'll do with them. But if they're organizational questions or questions about what Ocumel Canada does, or what you would like Ocumel Canada to do, Kathy and I will handle those. We did want to say that we have a very exciting project underway, investigating the diagnostic journey for ocular melanoma patients in Canada. It's a bit of a mystery to us. It's a bit of a mystery to individual patients even. How does this happen? The problem is, of course, that the disease hides. It's also a problem that it's incredibly rare. And so the first person who sees it in your eye may not even know, what they're looking at. So we will be reaching out shortly to Canadian patients through the Facebook group, the general group, and if we have an email, perhaps through that. It's nice for us to be able to be in contact with you. And we're hoping that there'll be a really warm response. It'll be quite a manageable survey that I think will take about 15 minutes, maybe 20 minutes, if you have to go back and look in some of your documents or some of your emails for precise information about your diagnosis. Very important to us. The study is going to happen fairly quickly. We'll be looking for volunteers shortly, and we hope to have the project wrapped up by March of next year. Anything to add to that, Kathy?
No, we're pretty excited about that project, actually. We did it not only in the cutaneous space, but we did it in cancer in general about 4 years ago with another group that we actually did called OM Canada. And really what we learned from that was about the problems in the diagnosis space, because we know early diagnosis is so important. So, when this year we were talking about how we wanted ocular to be a real prime focus for us, because we know there is lots happening in the US, really, and around the globe, but we want to kind of make sure we're getting in Canada. We thought in Canada, to be able to present, we need data, and we'll be able to collect as much data from the patients as we can for that report. So we're pretty excited about that as well. I will tell you, there's a lot of little things behind, or not little things, big things behind the scenes. And that's why it's, so important that we hear from our patients. We don't want to, be pesty, but it's really important to us. We know right now that Dr. Butler has 3 clinical trials happening in Princess Margaret. We've been really working hard behind the scenes to at least get one more center. We do know that Alberta is going to be running a couple of those clinical trials in the very, very near future, both at the Cross and at their new, it used to be Tom Baker, I can't remember the new name, in Calgary, but we're going to be seeing access there soon. So, it's really important. I can't stress this enough. And this is patients, that we're as close to home as we can be when we're on these clinical trials. You know, our support system, our families, we need to have them close. So we're hoping to see Edmonton open before end of year, Calgary same, and then we're going to see if we can get some more centers moving. Quebec actually beats to a different drum, but they work really unilaterally across Quebec. I'm actually quite proud of them in the way they run their clinical trials. So, you know, we should see some more opening there as well. So just, you know, be patient with us. We're trying to get these drugs to a center near you as quick as we can. BC, unfortunately, right now has been an outlier, but we just had an election cycle in BC, and we're hoping that, you know, we can go meet with some of these decision makers and see if we can put a little fire under their feet and get them moving as well. So stay tuned.
Thanks, Kath. I see that Sherry has joined us. You met her yesterday, and I'm sure you enjoyed her story. She's wondering if the Daro-crizotinib combination has been put forward to Health Canada approval, or is it too early in the trial? Well, it's the latter. It's phase 2 trial. Data is being accrued. And, you know, what we can always do is we can go to the originating documents on the trial, look it up, and it'll give you a sense of how it's moving and when they expect to move forward. And also, historically, the US moves before others, certainly Canada. So that would be an early indication. But from everything that we see, there appears to be something there, and I'm sure that it will lead to a therapy in the future.
We're always hoping that once the US approves that the drug companies bringing the drug to Canada will bring it in with the phase 2 data and at least submit for NOC, because then that starts the process moving. But again, a lot of these companies are smaller bioscience companies, so they haven't really had their feet on the ground in Canada in the past. So we're trying to work with them to kind of explain the process to them so that we can try to get those at least to NOC at phase 2. And then it just moves the process. It should move the process a little quicker. And that's what happened with the Kimtrack, honestly, is that's why it moved quickly, relatively quickly through our process.
Thanks, Kath. Let's say something about what is available for ocular melanoma patients in terms of, you know, regular or fairly regular support. We have a series of fireside chats that started, I think, in 2023, and they've been quite popular, and they continue. We actually had one that was focused entirely on ocular melanoma, which was a great success. And we do have some ocular melanoma patients who attend all of them, because often the topic is for patients, you know, who need help. And so you'll see a reference to an upcoming one, I think on December the 12th, in the notes at the end. Kath, did you want to add to fireside chats? Oh, and perhaps you could mention the support group.
Yeah, and now we're running what we call our Wellness Wednesday, and you're going to hear from Lyanne. I think she's our last presenter of the day, and you'll get to see firsthand a little of the work she does with us at Save Your Skin. We run those 2 Wednesdays in the month, and what it is a very small, intimate group. And we just kind of walk through some emotional wellness practices, meditation, breathing practices for those days when we want to stay in bed and pull the covers up over our head. And they've been very successful. So we invite you to attend those. We have cameras on, cameras off if we choose. And yeah, it's been actually, our patients are really enjoying them, and we really invite you to try to participate if need be.
Thanks, Kath. I just wanted to talk very briefly about fundraising. You know, in the groups, we protect ocular melanoma patients from advances by fundraisers of all kinds. And the only exception that we make is for the annual Save Your Skin Foundation fundraising, Move for Melanoma, which happens traditionally in September. I suppose that's open to change in the future. But we've most of the funding for patients over the past couple of years has gone almost entirely to ocular melanoma patients because the needs are so great, and the needs in cutaneous have diminished over the years because there are treatment options that work incredibly well for some, not for all. So you would expect appeals to appear in the room in the fall. And we've had Team Ocumel Canada for a couple of years now that has done incredibly well. So if you're feeling well, if the cause is important to you, and I'm sure it is, that would be the time that you would join in and help, either by donating or by joining the team or by raising funds in your own community, whatever way works for you. Did you want to add to that, Kath?
No, I'm just wanted to let Brianne know that I see her question or her comment in the chat. Brianne, if that's, something that you want to, become more involved in, you can always let me know. You can email me, Kathy at Save Your Skin. We do have the 1-800 number, but I always give everybody my cell because I kind of agree with you. I wasn't too satisfied with Dr. Butler's answer either. So, maybe Nigel, that's something, we'd like to do a little think tank about and see what we can do there. That's been something we've been discussing for a year plus, I think, feels like forever. So yeah, again, Brianna, I see your comment. Maybe you want to circle back with myself and we can have a little discussion about that.
Yeah, could I just add, Brianna, I know the process that you're going through at the moment and how that must feel. And so my heart goes out to you. I would just say that, histotripsy is a very new technology. There's no direct association yet with helping ocular melanoma patients. So there's absolutely no history. There's been no clinical trial. There's been no documentation of whether it extends life, which would be the most important thing. We know that liver directed treatment can be an immensely important component. But histotripsy, the story is just beginning. And it's wonderful for us to know that it is a real interest to you. So certainly follow up with Cal.
And I know sometimes for patient, it feels like forever to get things moving, but we are the voice. And what I will tell you in Canada is I'm really proud of not just the work we've done, but the work that's been done before us by a lot of patient organizations that, have people who have been movers and shakers in the space for 20, 30 years who kind of set the path for the rest of us. And, we're now in the melanoma space. We went from having nothing to now seeing treatments in adjuvant, neoadjuvant. We're seeing really successful data coming out of studies that actually we didn't even run in Canada, unfortunately, where we're giving treatment before we start cutting anywhere. And some patients are getting 2 doses of treatment and then there's no surgery and, they're curative or they're at least progression free for 2 to 3 to 4 years. So I know it feels slow in the ocular space and it is, there's no doubt about that. But we're actually already seeing neoadjuvant trials being done, by Dr. Butler at Princess Margaret. We're starting to see a little shift. And we can move that shift quicker when we have all of you kind of behind us. So I know I beat this drum all the time, but we love to hear from you what your needs are, because that's how we build Ocumel Canada and Save Your Skin. What you need is what we will build for you. So please always reach out to us, no matter what the issue is, no matter how small, no matter how big, because we don't even, it's not just about financially helping you, it's helping you through this journey, however we can. So if there's anything, a resource that you would have liked that we don't do, if there's a webinar that you would like that we haven't done, you just let us know. And, no ask too big, no ask too small. We'll try our best to deliver in a timely fashion. That's the one thing that we can do. Our hands aren't tied by any government agency or any government bureaucracy. So we will do what we can to help you through the process.
Thanks very much. And we had another question come in about histotripsy. And so hopefully that person has been listening to the discussion. Let's have a little chat about leadership. I think everybody will know that Kath spends her days and her nights advocating for melanoma patients. And she needs lots of help from lots of people. I think my friends will know that I have been trying to step back because I am aging. I've been lucky enough to survive to my late 70s. I know I'm less sharp. And so I have backed away from day-to-day involvement. And so there's opportunity there if you feel that you have something to offer in terms of advocacy, in terms of patient support, in terms of reaching out to cancer centers in your province, for example. I think the process would be that you would contact Kathy, whose number will be up at the end, and have a chat about what it is that you would like to try and contribute. Kath, does that sound kosher to you?
Kosher it is. Yeah, I mean, I know all things cutaneous melanomas. I know all things skin cancers now because I'm aging too, which I never thought I was going to. So there's a benefit to that. So I'm starting to see all sorts of basal cells, squamous cells, and everything else. But you're the experts. I can open the door. I just need your help getting that door open and your expertise. So I know, when you're in the middle of this, and I hate to use the word journey, you've got a lot going on in your life, but any little bit you can add, or you let us know. Again, we'll try to do our best. Martin and Myrna, I'm reading both of your questions because our system right now needs a little bit of an overhaul. We know that. That's just another big project we work on. Every time there's election, Kathy Barnard is out knocking on doors because, as you know, we have a problem with primary caregivers. We have a problem all over Canada with getting specialists that we need, whether it be ocular or cutaneous. We have no dermatologists. We're not getting timely MRIs and scans. Right? Our patients aren't happy with their care. So this is where I have to stress, you are your best advocate. You really are. I always say, we actually are the bosses of all those politicians, and actually we pay, our doctors are paid through our tax dollars. We are their constituents, and they're there to give us the best care ethically that they should. So I think when I said to you the other day, if you have a good advocate, supporter in your family, whether it be a family member or somebody outside your family, and you have concerns about the care you're getting, you need to address those concerns in the most diplomatic way you can. That's really important. But that's really important. Same for you, Martin. If you don't think you're getting those MRIs in a timely fashion, you need to be talking to your healthcare person. Sometimes I think the people in our areas that have a good GP or primary caregiver have a little bit of an advantage, because sometimes they can be very instrumental in giving the system a little nudge. So if you have a GP or primary caregiver that you've had for a while or that knows your file, I suggest that's where you start. It's not as easy for Save Your Skin or Ocumel Canada to do the nudging there, because what we'll be told is, unfortunately, our physicians and our oncologists are just as frustrated with the system as we are. But again, you are your best advocate. And if it's not in you to give or to be, if you have somebody within that support system that can be that person, take them with you on those visits and see if you can start moving that process a little quicker. I will tell you, you're not alone. It's happening really everywhere. In all cancers, just the backlogs in the system right now are really causing, a lot of pain in our patients.
Thanks, Kath. That's a lovely, kind, and thoughtful response. And maybe I would just add that, one of the things that drives us, especially if we have metastatic ocular melanoma, is that we're terrified of what lies ahead. And it's easy to lose sight of who the enemy really is. And often we pick on our oncologist when maybe that's not the real enemy. It could be that you're just so upset about having a dangerous disease that is progressing and nothing that you're doing seems to be working. We live in an age where it's always appropriate to say to a service provider, I'm not feeling listened to, so I'm going to say this again. Talking like that is okay. Kathy mentioned the word diplomatic, and of course, we live in Canada. That's a very important word here still. Thank goodness. So I would encourage you to be brave in your conversations. As Kathy says, try to have a really good advocate with you, whether that's a family member or a friend. I think that will really help. Yes. Okay. So I think we've caught up with the questions. Kath, is there anything that you would like? Maybe I could just add this as a segue that Kath and I have talked about this many times. Like, the hardest part of the frightening part of the journey is tending to the wellness of your mind as much as tending to the wellness of your body. So we have a session just coming up that helps with that. But a lot of people reach out to me and say, what can I do? And I do often say, have you used the services that are available through our cancer agencies? The very best things that I did years ago, when I was very frightened, was I reached out to the cancer care counselors. They were just extraordinary at their work. And at one stage, one of them was concerned enough about me to refer me on for further help, which I found extraordinarily helpful. So that's just a personal testament to working with the professionals that we have in the system. Yes, Kath is right, they're overworked, there aren't enough of them, but certainly reach out and ask what is available to you, no matter what stage of the disease you are at.
And I don't want to end our session without talking about our caregivers and our loved ones that are kind of running through this journey with us. It's really important too that their needs are met, emotional needs are met. So, we're hoping, and we always do think about the caregivers when we're building our webinars and our support systems. But if there are any caregivers on this line, I always say we all walk a different path. throughout our cancer processes. And it's really important to us that everybody, all of your loved ones are on the path. They're not straying into the weeds. We need to make sure that everybody gets through this at the end of the day, united and together. So, you know, if there's any caregivers or if any of your caregivers would like some support that we don't have, that we should be building, or we can refer you into any of the cancer centers that might have those one-on-one supports, please let us know as well.
Yes, and often it is a caregiver who will attend the fireside chat on behalf of the patient who's maybe not comfortable, being that up close with a camera, and the support group. So maybe we will use that as a segue then to move to our next session. And it is the final session of the day. And so I'm excited to introduce Lyanne Westie, a wellness support consultant with Savior Skin Foundation. Lyanne brings a wealth of experience in mindfulness and compassionate counseling, helping clients explore the connection between their mind and body while fostering curiosity, self-compassion, and trust. Drawing from her own journey of healing from chronic pain and trauma, she emphasizes the importance of feeling safe, seen, and heard, and she creates a nurturing space for self-growth and healing. So I'll now hand it over to Lyanne to guide us through her session. Over to you, Lyanne.
Hi, everyone. Thank you so much for inviting me to speak today. My name is Lyanne Westie, and I am a counselor, life skills coach, and wellness consultant for Savior Skin Foundation. And I was asked to speak a little bit today on wellness and self-care with this focus on decompressing as a patient or a caregiver. Just a few talking points for the 30 minutes that we will have together. And so one of the first things we're going to do is we're just going to do a little check-in, a little pause. Then we're going to move to some information on self-care. We're going to look at the dynamic nature of self-care, and then we're going to look at some support needs. And so I thought maybe it would be nice. This is the second day of the symposium, and probably receiving a lot of information and listening for a lot of information. And so I thought it might be nice as we start out just to take a minute or two and take a breath and check in. You might be noticing that often what happens when we're listening, or we're sort of worried, or we're observing quite intensely, that we start to tighten up. And so I thought maybe it might be nice to just for a second just maybe notice how you're sitting in your chair. If you're sitting like this, if the shoulders have come up or there's sort of a tightening as you're sitting there, and maybe just noticing if there's any way you could soften your shoulders, move in your chair if you need to. It's not uncommon to hold your breath when you're focusing intensely or listening for something important. So maybe even as you're settling your shoulders or noticing any tension, it might be nice to just bring your attention to your breath for a moment and see if there's a way to just maybe slow the breath or notice the breath again and let yourself come to breathe. One of the things, and we'll get to some of the self-care, but one of the things that in those moments where we're quite tight, that can be quite supportive, is to take a slightly longer out breath than in breath. So even as we're sitting here, and we will switch into the information, but even as we're sitting here for a moment, just taking a second. Taking a breath in, and just seeing if there's a way to extend the exhale by just a few moments longer than the inhale. And as a way of sort of slowing down the body, settling down the nervous system a little bit. Yeah, it's a lot of information over the 2 days. It's likely very emotionally charged information for both patient and caregiver and those hosting. So maybe a chance to just pause for a second and notice, maybe even noticing your hands, your arms, your legs, just taking that check-in to see if there's any areas you could soften as we move into some of the information that we're going to talk about over the next 20 minutes or so. Move to just a bit of first a definition. It can be helpful. The World Health Organization, if we look at self-care, which is one of the ways we can come to support ourselves, that idea of kind of emotional regulation, physical support, that softening or letting go of tension, self-care is a really important topic. And so we're going to look at the definition of the World Health Organization, and then I'll move it into a bit more user-friendly. The ability to promote health, prevent disease, maintain health, and to cope with illness and disability with or without the support of a healthcare provider. And so one of the first things I often like to mention with self-care is it doesn't require that we're doing this alone. So self-care sort of notices that we're meeting ourselves, we're taking care of ourselves, but that does not require us to be doing that alone. So self-care might include a healthcare provider, and self-care might include some of the things that you're doing outside of those appointments or outside of those meetings or during your day-to-day that are helping you to maintain your health, to navigate illness, to promote your own health, the things that you can do between those appointments as well as during those appointments to support your overall well-being. So a bit more user-friendly term or way of describing it is that self-care is the practice of intentionally taking time to care for your physical, mental, and emotional well-being. It's about doing what helps you recharge, feel well balanced, and to meet your needs in a way that supports your overall health and happiness. And you'll notice there's a couple places here that I've put in italics, and that's sort of my intention for today, for the time that we have today, is really to narrow in on this place of that it's this sort of intentional action, these choices that we're making. We're going to come back to that. And that we're not just supporting one aspect of our well-being, that we're really looking at the ways we can support ourselves physically, mentally, emotionally. That extends further than that, spiritually, occupationally, financially. There's many different areas of our life where we can support our well-being. Today we're going to look at sort of the physical, mental, emotional, and then that it's how we help ourselves to meet our needs. So very specifically that you uniquely have certain self-care needs, ways of supporting yourself when you're feeling stressed or tense, and really wanting to narrow in on how do we support you uniquely to support the needs that you have for your wellness. One of the things about self-care is that often if you look up self-care online or you sort of go through the internet to type in, self-care, how do I help myself out, is you're going to see an image of a really beautiful setting, which is wonderful, and also someone likely in a yoga position or with some candles. And it is true that that is one way that people support themselves to feel calm and relaxed, but that is by no means what it means for many people to be meeting themselves in self-care. Emotional regulation is a really important piece, but how we do that is going to be as unique as the number of people in this room watching today. And so, although you'll see pictures of candles and yoga and these beautiful landscapes that, we find quite calming to look at, I wanted to sort of start by reminding that we all find that way of decompressing different. And so I went in and found a couple of photos that I think represent a little bit of that, which is that you might find reading to be the way that you decompress. Maybe dancing, maybe going out, moving your body is how you decompress. Maybe it's exercise. Maybe it's art. Maybe you love to draw. Maybe you love to paint. Maybe you crochet. That how you support yourself with that need of decompressing is something very creative or artistic. It might be with your pet, your companion, some time together. I also like to add that self-care might be work. You might find that that's your place where you feel purposeful and intentional and you get to focus on something. It allows you to sort of concentrate. So work might be your place where you go and you get to decompress. Might be a car star like myself. Singing in the car is a way that I find allows me to move some energy. Maybe it's about being with others. Maybe your way of decompressing is to be in a social setting, something here, or maybe you find that alone time is where you decompress, that having that time to yourself is where you decompress. Maybe, and I've heard this from so many people, and I love this, that often it's some of those really quick, friendly interactions with a barista or someone at, behind the till, or someone in the grocery store, or someone where you're getting a quick hello. It's a wonderful interaction and you're getting that moment of sort of calm. So again, that's a place of self-care. Dishes are not my self-care, but I have spoken to many people that actually really find that to be a mindful practice where they sort of clean or they find themselves doing dishes and can be in that place. So I really want to remind, as we go through the next little bit here, that self-care is so unique. How you decompress, what that looks like for you is uniquely yours. And so one of the pieces that I really want to speak to in this place is these two places of self-care. So one, to be able to meet yourself in care, you need to be able to identify the need that you're wanting to meet, and then to actually meet those needs in ways that are supportive. So the next little bit of information that I want to speak to is this dynamic, personalized nature of self-care. And one of the ways that we help ourselves to decompress, one of the ways that we support ourselves to feel emotionally regulated, to feel physically well, is to begin by identifying our needs. What are our needs for care in that moment? One of the pieces I'm just going to speak to, and I've got just some talking points here on the screen, but one of the things that I think is really an important mention, especially when you are facing medical health challenges, physical health, emotional challenges, is that your nervous system, if we look at it at the nervous system, is likely for yourself, for your caregivers, I don't want to make this all or nothing, but is likely in a place of sympathetic. So in that place of anxiety, uncertainty, worry, fight, flight, freeze, fawn. You might even be in a place of shutdown. Everybody meets these experiences differently, but you might find that your nervous system is in a place of feeling under threat. And one of the things to consider in that space when you're looking at how to support yourself and the importance of that intentionality of supporting yourself is that when we're in that sympathetic state or in that dorsal parasympathetic state, is that we really are cued to look for danger. So if your system is in that state of survival or feeling under threat, it starts to sort of narrow in to looking at the world for the things that are going to be danger, looking for the things that need to be avoided. And so we can really start to narrow in on those cues. And part of decompressing and part of self-care is intentionally sort of expanding that view to notice the things in our life that support us with safety, support us to feel safe, support our nervous system to feel safe, support our nervous system to feel in connection. which is why, social support from our peers, peer groups, support from our friends and family really support our nervous system to feel safer. And when our nervous system feels safer, we're cueing less to those things in our environment that are perceived as dangerous. So I just really want to sort of name the importance of that intentionality to bring into our experience, to notice the things in our experience that help us to feel safe. You might notice that that's where sort of the mindfulness practices, the grounding practices, the safety meditations, the visualization meditations where you're imagining yourself in a calm, safe place are all designed to help intentionally move us from that sort of fight or flight, observing to avoid threat, into a place of feeling safer, our nervous system feeling safer, so that we can interact more in our environment and look for other cues in our environment. So in this space, that intentionality becomes quite important to be consciously looking for ways to remind yourself that you're safe and in connection. As we're looking at how to bring self-care in and how to decompress, you may find yourself needing to be mindful of some of the limiting beliefs. This is for both caregivers and patients. Some of the limiting beliefs or core beliefs you might have around meeting your needs. So it is not uncommon to feel that taking time, especially as a caregiver, from caregiving to support your own need for well-being and your own need for safety and your own need for well-being, to feel guilty or ashamed or having a hard time balancing taking care of yourself and taking care of someone else. And again, most people that I speak with really have core beliefs and limiting beliefs around their right to self-care, their right to take care of themselves, to slow down, to meet their needs differently than others. That maybe for you, moving constantly is how you support yourself, and you're in relationship with others who like to sit still when they are supporting yourselves, and sort of navigating that it's okay for you to have the needs that you have for self-care and to meet those in the way that supports you. So this is one of those places when you're identifying, what do I need to feel better? What do I need to regulate myself? What do I need to support myself physically, emotionally, socially? To recognize that you may have limiting beliefs or core beliefs that push up against that and actually make it feel like you kind of have to walk sort of uphill to meet that need. And those are a really great place when you're talking to others to see if you can notice. For example, one of the examples that actually comes up for me in this place all the time is one of the ways that I support my well-being is to have a tea in the morning. And it is something that I have put into my schedule. I wake up, I have my tea, nothing starts in my day until I have sat and sort of slowed myself into my day, been mindful and enjoying my tea. And of course, that's knowing that when I take that time in the morning to do that, that I can kind of hold that movement into my day. But if I start a bit more scattered or I'm rushing then my day tends to go from there. So this is something that I've learned to do for my well-being. Now, that tea really supports me. Later in the day, around 3 o'clock, when I'm needing that break or I'm noticing, I've been running on, full speed for all the day, I go to have a cup of tea, which again, in the morning, I've set aside that time to meet that need. But in the afternoon, there's still beliefs around pausing right now is not okay. Stop being lazy, get going. This is not the time for stopping. You should just get that work done. And so noticing that my beliefs around when it's okay to take a break, what it means if I take a break at that time of the day, actually impacts my ability to sort of receive the benefits of taking that 15 to 20 minute break and resting and calming. And I've managed to navigate those beliefs for my morning, but still working on it in the afternoon. So I just kind of wanted to give a tangible example of how that might be showing up in, your day as well. So being mindful of those places where you're sort of resisting or pushing back or hold beliefs that keep you from feeling that self-care would be supportive. The other place around needs that I wanted to speak to was around this place of sort of this whole scope of areas that you can meet your needs. And that when we're navigating a physical illness or the emotional aspects of that, there's also truly impacting all levels of well-being, that we might be finding it quite difficult and really focused on the physical, but the reminder that if we sort of see all those areas of our life, that we can be doing things in any of these places, in our spiritual well-being, in our social well-being, in our even financial and occupational well-being, and everything we're sort of supporting is supporting that wholeness, right? That space of sort of filling that cup, if you will. So the reminder is sometimes to just pan back out a little bit and notice all the areas of your life. And you could look at the 8 dimensions of wellness for this, but just kind of panning back out and noticing if there's any areas that you could bring some attention to that would support your overall well-being. So identifying needs for support, identifying needs for self-care is the starting place. So then once you've identified, I have a need for physical movement, or I have a need for rest, or I have a need for social connection, or I have a need, for example, to take a bit more time to myself, that the social being out and interacting all the time is a bit more tiring. Once you've sort of landed on that place of what my needs are, then we actually want to go to, then how do you meet your unique needs? How do you come to that place where you're getting to rest or be active, if that's how you meet that need, but that you're meeting that care, that self-care. And so, sorry, I'm just gonna grab a sip of water. That when we move to how to meet your unique needs, one of the places that I would encourage you to begin is looking at the existing resources and practices that are already working. So you have, across all of your life, develop these ways of caring for yourself, and some of them might be sort of consciously, that you're doing them. Others you might be already doing them and not even noticing that these are things that you're doing in your day that are supporting your well-being. So one of the places that I really encourage people to start is to actually bring those into sort of your awareness, bring them forward so that you can look at, okay, one of the things I do each day is I go for a walk, or one of the things that I do is I have my cup of tea. One of the things that I'm already doing is maybe you're calling a loved one and talking to them during the day. One of the things you might be doing is journaling. So I'm trying to come up with examples, but truly these will be unique to you. So just really noting, what are the things that I do that if I think about it, maybe we could even just pause for a moment and start to notice what are the things that you do? What are the things that you're doing right now, or maybe have been doing recently, that support you to calm, or that support your nervous system? And I just use the word calm, but again, that reminder that part of that could be very active. So I apologize. Some of the things that you're already doing, and noting them down, because what we want to make sure is, if you already know that those things support you, and right now there's these things, and then there's going to be things that you've done in the past, so that's another place to then, once you sort of notice what you're currently doing, taking some time to notice, apologize, what have I done in the past? What are some of the things when I went through difficult things in the past that helped me? Am I doing those right now? Is there ways to bring those back into my routine right now? And one of the reasons for starting with the things that are working, too much talking. One of the things that about starting with the things that is that it's easier and more likely to integrate and use practices that you're familiar with than to be learning something new. Not that we don't want to bring in new practices, but learning something new. I apologize. So really focusing with what's working and then building from there. So that's one thing. Really be mindful of what's already working and see if you can really ensure that those things are part of your day. The next thing I wanted to talk to in this space of meeting your unique needs is to be sort of conscious of and aware of outdated supports, supports that might not be available to you currently, or unsupportive resources, practices, and expectations. And that's really a lot of words. So to sort of bring that down is to notice the things that you may have done in the past. For example, back in the past, I would have gone out for a, anywhere between 2 to 10 kilometer run to move some of that stress. And that was a really supportive way. I would go out and I would play team sports. That was a really supportive way for me to meet my stress and overwhelm. Unfortunately, because of physical health issues that I have at this point, those resources, although they were parts of my routine for so long, are not currently available to me. And that's a really hard place because, and I imagine that you may have some of these in your life, there's sort of a longing or a familiarity to turn to those supports. And so part of meeting your unique needs is also being mindful about what is currently available, and not when we're banging up against those places of, but I used to, or this used to be available, and sort of wanting to lean into those resources. We might be missing out on ways of supporting ourselves now that are more available, that we're not hurting ourselves or harming ourselves to do, and that are more aligned with what we're able to do at this moment. Another example may be of an unavailable or something that's changed is your needs have changed, and currently even the experience that you find yourself in, your needs may be substantially different than they were a month ago, a year ago, 2 years ago, when you developed some of the ways of caring for yourself. And so one of the reasons for checking in with your needs first is that we can then actually notice, what do I need right now? And maybe in the past, going out into big community events or going out into sort of big social events was one of the ways that you supported yourself. And right now, maybe those big groups don't feel as supportive, or maybe some of the volume of social activity doesn't seem as manageable. And so really sort of being mindful of, even though this may have been a way that you've supported yourself in the past, that it might not be well matched currently to the needs that you have. So this sort of shifting and noticing, and some awareness to how what you're doing is actually meeting the need that you have. So just that space. One of the other things that I want to speak to about meeting your needs is this difference between, well, we'll always sort of react, but this place of response. One of the reasons, especially under overwhelming, distressing, stressful experiences, is that we do have these sort of reactive ways of coping. And some of those ways are effective, but maybe harmful in the long run. And so one of the ways to be mindful of the ways that you're supporting yourself, to be intentional about putting things in place, is to buffer against this sort of natural reaction to potentially move into ways of supporting yourself that may actually be harmful. And building self-care, building resources, building ways of supporting and sort of supporting with resources that have sort of current health and long-term health in mind, is to sort of prevent or reduce the chance of moving towards supportive strategies that are harmful. As again, we want to be navigating the big emotions we want to be. And there are ways that we can numb those emotions that are more harmful in the long term. And I could talk about these things all day. I know I need to keep moving from this slide, but these are really important pieces. In this space of meeting your unique needs is if we start with what we know, we're intentional about putting things in place. We build with some of the things from the past that have worked. We're mindful of the things that aren't supporting anymore, aren't aligning with our needs. We can then, from that place, start to get curious about what else might be available, right? What other resources? What am I hearing from other people that they're doing? What could I try on? What might be supportive? And we can start to build on what's already working. So that was a lot of information, but just again, that simplifying down to how do I notice what I really need right now? And from there, how do I meet those needs intentionally, supportively, with what's available, so you're not putting too much more stress upon yourself, like with what's worked, with what is working, so that I can be responsive, so I can be responding to what's happening. I do have one last slide, and I see that I am right down to the last few minutes, and this is going to carry with that same theme. But where we find ourselves in this last slide is on this place of meeting support needs. You remember at the beginning, I was speaking about our nervous system and how when our nervous system feels safe, when our nervous system feels in connection, when we feel safe or perceive ourselves as safe, when we are in connection or in perceiving connections with others, our nervous system tends to feel more calm. So one of the places where I really want to encourage, and I apologize, this is probably, it is a PDF, and I could, the types of support that are available that you might want to be looking to, I could always get sent as a resource, so I apologize, that's probably pretty small on the screen to look at. But the reminder from this screen, as I'm getting close on time, is that there are so many different types of support. And that there are going to be different people in our lives, different resources in our lives that can meet these different areas of support. And there are also going to be people and places in our life that are not well matched for certain types of support. The example I like to give here is that there are people in my life that are very good at offering informational support or unsolicited advice, or we could call it informational support. And sometimes that is very, very helpful. And other times I am in need of emotional support, someone that can offer empathy, care, love, help me to feel understood and valued, for example. And if I notice that what I need in a particular moment is emotional support, and maybe I go to someone that's really good at informational support or accountability support, I'm not necessarily meeting that need. And that can put sort of strain on the relationship. It can actually make it feel like that need isn't being met. And so my sort of encouragement and gentle sort of reminder is, again, this place of identifying needs and then meeting needs for when we're wanting to decompress, when we're wanting to feel sort of regulated, is to start to notice what need you have. Is it for example, emotional support? Is it for someone who can sort of validate and normalize? Is it someone that can help you with accountability if you're looking to start a new practice? And once you've sort of noticed, this is the type of support that I would be most helpful right now, then we can start to look out into our communities and into the people and places and things that we have around us. This could be pets, this could be community supports, this could be sports, this could be mentoring, this could be professional help, but finding the way to meet that need. And so this resource just sort of names and notices those different types of supports and can be a starting place for checking in to notice, what supports do I have in place? What supports do I need? Am I meeting my need for support with the right support? So am I, again, matching the need with the correct support? So, wow, this time went very, very quickly. I'm grateful for the opportunity this is something that I'm really deeply passionate about. I feel like this space of self-care has so many ways of being supportive. And so I am going to bring it to a close there. I have pre-recorded this, so unfortunately I am not in the space for any questions, but I do welcome any questions. If you have any, you're welcome to message, and I would be happy to talk a bit more about these topics. So thank you again for the opportunity to share some of this information, and really wishing you well for the rest of the symposium. Okay, take care. Thanks. Bye-bye. I am right down.
Thank you, Lyanne, for that calming and insightful presentation. And thank you to everyone who helped make this symposium possible. In particular, to Kathy for continuing to champion the cause and being there for patients at their moment of greatest need. Thank you to the Save Your Skin Foundation team, Jasmine, Laura, Katie, Amy. You've done a fabulous job of pulling this together and doing all the work in the background to make it run smoothly. We have a couple of questions that we may not have addressed sufficiently, so please be assured, Martin, that we will follow up on your queries about scanning. Nothing's more important than getting our scanning on time. I'd like to remind everyone who's still with us that the video recording of the symposium will be available on the Save Your Skin Foundation YouTube channel in the coming days. It will also be emailed to everyone who registered, and it will be accessible on our website under the Ocular tab. If you have any questions or would like more information, please don't hesitate to email us at info@saveyourskin.ca. We're here to help. That email address always works. I'll repeat it, info@saveyourskin.ca, and you'll see it up on the closing slide. As we wrap up, information about our upcoming events, website, Facebook group, and my email will be displayed on the screen. I can't tell you how wonderful it's been to see so many of you join us over the past 2 days for our second annual Ocular Melanoma Patient and Caregiver Symposium. Above all, we hope you walk away knowing that you are not alone. You have a team on your side and by your side. Please reach out anytime you need support. One last reminder, don't forget to visit our website and Facebook group, which you'll see on the screen shortly. In the coming days, you'll also receive that email that I talked to you about. That's it for now. Thank you for being part of this event. Thank you for leaning into Ocumel Canada and making it work to support patients as they come to us. I see a new patient in from Ontario just this morning. And we look forward to seeing you this time next year. Merci beaucoup. Bye-bye. Au revoir.